As everyone knows, we've been very impressed with recent results with PD-1 inhibitors in general in a number of indications, but especially non-small cell lung cancer, where in general there's been a large unmet need for newer therapies to really advance survival and improve survival, etc. And so we conducted this analysis based on studies that we received at the FDA, basically to see past the traditional RECIST response progression, how patients do. So there's been a lot of anecdotal evidence, sort of like a case by case, where patients who have had maybe a slight increase in their tumor but otherwise have done well, clinicians have decided to continue treatment, and those patients have potentially done better later, despite that they met criteria for RECIST progression. So based on these anecdotal cases, a lot of the large phase 3 trials have actually included that as a criteria, meaning that patients who are on a PD-1 inhibitor, for example, could continue treatment even if they met criteria at some point for RECIST progression. Of course, not all the patients, most patients did not continue treatment, and there was some criteria, albeit somewhat subjective, but if the clinician, investigator felt that the patient can continue treatment, meaning if they were doing well and they felt that the patient was deriving clinical benefit, if there wasn't a lot of toxicity, and of course if the patient agreed, signed informed consent, that was allowed. So for us it was really interesting because we knew that there were these cases, but we wanted to see sort of on a larger data set, including a number of trials, what actually happened to these patients who were continued past the traditional RECIST progression. So for most solid tumors and for non-small cell lung cancer, we use the RECIST criteria. And basically RECIST stipulates that if patients, if they meet criteria for progression, which is specifically if they have new lesions formed, or if their tumors get larger, the target lesions get larger than 20% compared from the nadir or baseline, and then, or if they have new lesions other places, that meets criteria for RECIST progression. Those patients who met that, as I was mentioning before, some of them, they were otherwise doing well. So it could be that some patients, for example, were having further tumor shrinkage, but developed a small lesion somewhere else. So based on this conventional RECIST criteria, that would make them, or give them the title of progressive disease, and using more traditional therapies, we would stop the treatment saying that, hey, if there's a new lesion that developed, that the drug is not working anymore. However, because this is immunotherapy and because of the previous anecdotal cases in general with checkpoint inhibitors, a lot of these trials allow for treatment past that first progression. So we chose 3 trials evaluating a PD-1 inhibitor, and altogether when we pooled the data from the 3 trials, we ended up with 535 patients who received a PD-1 inhibitor. So then we analyzed who those patients were, what were the demographics, etc. And then we want to really look at which patients were chosen to get treated past the traditional RECIST progression, which I refer to as TPP, treatment past progression. So out of the 535, 121 patients were chosen to get treated past progression. As I mentioned before, when I say chosen, it was up to the clinical investigator. The patient was doing well. There wasn't overt toxicity that would limit the treatment. So out of those 121 patients, then we went and we actually looked that once they were receiving treatment past progression, what happened to their tumor target lesions radiographically. And when we did that, we used sort of a criteria, again from RECIST, we used a 30% cutoff, meaning we wanted to see how many patients had tumor shrinkage past that treatment past progression with a 30% decrease from their baseline target lesions. And so when we did that, out of the 121 patients, 10 patients met that criteria, so approximately 8% of of the 121 patients. And if you look at, sort of the larger picture, it's about 2% of all 535 patients. I think there's two important questions here. One is always at the patient level when you're seeing the patient in your clinic and what to do for each individual patient. And then the second issue or question is sort of on a larger clinical trial standpoint to whether RECIST is good as a criteria to use for endpoints and objectives, etc. So at a patient level, I think, as I mentioned, out of 535 patients that received a PD-1 inhibitor, 10 patients had some, 30% tumor reduction. Clinicians have to be really careful on who they decide to actually treat past progression. There's no magic number like 50%, improvement or anything like that. And even more importantly, which is in my presentation, a lot of those patients who actually, out of the 10 patients, in general, they were most likely healthier patients. They had diseases that had overall, irrespective of treatment, probably a better natural history, a better course. They initially responded to the treatment better than the general population. The risk, as you know, is immune-related adverse events. So because we're priming up the immune system to attack the tumor, unfortunately sometimes that also affects the normal tissues. And so we have to be careful, and at the patient level, I think if patients potentially are doing very well, let's say for example most of the tumors are shrinking, except there's one new lesion and there's a question to continue, and otherwise the patient is doing well, good performance status, it may be okay to continue it, but I think we have to be cautious for all the other patients that don't really meet that criteria. The second point is sort of in a more global clinical trial perspective. It appears that regardless of whether we use the conventional RECIST progression criteria or RECIST criteria, or whether we want to include newer clinical trial endpoints or newer ways to sort of account for potential pseudo-progression, at the end of the day, it probably doesn't make a difference. In this case, it was less than 2% of patients from the whole population of patients treated with the PD-1 inhibitor that actually achieved any tumor shrinkage benefit. I think lastly, the most important thing I want to stress is all these analyses are retrospective. There's a lot of patients, 535, which is good, but again, these are all retrospective exploratory analyses. And really to come down to the answer, we have to do randomized control trials prospectively to specifically answer this question so that the answer that we have is really data-driven.